Now let's tackle the basal ganglia. Basal ganglia have several nuclei in this cluster. In fact, actually it should be called the basal nuclei because the term ganglia is supposed to mean any place you have a gray matter outside the central nervous system, and the basal ganglia are clearly inside the central nervous system, so they should be the basal nuclei. But hey, the name has stuck. So we have several parts. Of course, the caudate nucleus, which more or less follows along where those lateral ventricles are. Here they are in cross-section, and here it is in a lateral view. It's, of course, deep to the surface. This is just projected to the surface so you can see where it is in relation to the rest of the brain. And then you have the putamen and the globus pallidus, and to me that forms like a pizza-shaped area where the putamen is a really thick crust, and the parts of the globus pallidus is where all the good stuff is. And then we have our substantia nigra and subthalamic nuclei low down here. So those are the main parts of the basal ganglia. There are some other terms that will put two parts of the basal ganglia together, and why not give it another name? So the lentiform nucleus includes the putamen and the globus, and the corpus striatum includes the caudate and the lentiform. So there's some more terms. Now the neural circuitry of the basal ganglia, I'm sure Dr. Bartlett has gone into exhaustive detail about what is connected to what, but we're going to simplify it for our purposes, for functional purposes, into two basic circuit patterns, the putamen circuit and the caudate circuit. First, let's look at the putamen circuit. And this is the principal pathway through the basal ganglia for executing learned patterns of movement that are already established, been used over and over again, and it helps to facilitate its use. And over here I have a really simplified circuit for this, that generally the putamen circuit has inputs mainly from areas of the cortex, mainly adjacent to the primary motor cortex itself, but not necessarily the primary cortex. But anyway, some various sundry areas that have something to do with motor control. And that goes to the putamen, hence the name of the circuit, and then it'll go to the globus pallidus, and it'll either go from there to the substantia nigra and the subthalamus, then to the thalamus, or it might actually just directly go to the thalamus next without going through the substantia nigra or subthalamus, and then head back to the motor cortex. So that's generally the pattern we see. Outputs from here in terms of where in the motor cortex, this goes to the primary, premotor, and supplementary motor cortices. The dysfunction of the putamen circuit gives you a little bit more of an idea of what it's there for. And so when it's broken, you can tell what it's preventing when it's working appropriately. And generally, the basal ganglia have, yes, both excitatory and inhibitory circuitry in there, but the inhibitory circuitries are really important in that they prevent unwanted movement. So when the basal ganglia isn't working, you have an emergence of some of these weird movement patterns. For instance, athetosis, which is a writhing kind of movement, usually involving the hands, arms, neck, face, and the globus pallidus being lesioned tends to cause this athetosis kind of pattern. Hemiballismus are sudden flailing movements of a limb, and the subthalamus tends to, when it's lesioned, tends to have that pattern emerge. Chorea, with a CH, chorea, that is more of a kind of a flicking movement. It's tick-like, but it's not like some other sorts of neurological disorders that you might call tics. But it's a flicking kind of emotion. Again, usually the face, but can be other body parts as well. And the putamen lesions can lead to this chorea pattern. Sometimes the globus and putamen, if they're lesioned together, you get a combination of choreoathetosis. You put those two words together. Parkinsonism is any disorder that has to do with a problem with the substantia nigra itself or anything responding to the substantia nigra. And Parkinson's disease is a specific thing. It's specific to the substantia nigra not being able to produce enough dopamine. But any other kind of disorder that's similar to that has a similar problem is Parkinsonism. It's more of a broad term. In which case you have a really interesting constellation of movement disorders, where in one hand you have rigidity and difficulty in initiating movement, akinesia, that's what that means, difficulty initiating movement, but at the same time you have those resting tremors. We have just this kind of shake, this head shake or a hand shake, sort of like this, but it's at rest, not while you are progressing through a movement. But once you get moving, right, that tremor tends to subside a bit. At rest, when you're sitting there, you're rigid, it's hard to initiate or start a movement with this. Okay, the other circuit, the caudate circuit. This is associated with what they say as cognitive control of motor activity. So they're trying to say things like the thinking and process, integrating your memory with sensory input, and then put that together with motor behavior. So it's like a working memory, a spatial working memory for motor activity. You can't really do a coordinated plan or develop a coordinated motor plan without having this memory and sensory input kind of mashed together and processed to has a framework for making a decision about motor movement. So the caudate nucleus is helpful in coordinating some of those activities. All right, so the caudate would receive lots of motor and sensory input from all kinds of places in the cortex, and goes to the caudate, not as much going through the putamen, since it's called the caudate circuit, although a few of it might go there, but it's going to mostly go next to the globus pallidus, then to the thalamus, and then back to that frontal cortex, mainly prefrontal, premotor, and supplementary motor. Prefrontal we haven't talked much about yet, but we will a little bit later. But prefrontal cortex is not specifically motor, but that's where, again, your what's called working memory is. That's where you contemplate things, in a sense, where you bring your experiences and your current sensations and have your current thoughts. Often that is very, very frontal in that prefrontal area. So you can see how this has more to do with some planning kinds of thinking. Now, the caudate nucleus, a couple of examples of it in action. And this is some examples I got from your text. Now imagine if someone writes a letter A on with a pencil on a small piece of paper, and a little tiny A. And then you ask them next to draw that same A in the same kind of shape, the same configuration, except draw it on a chalkboard that's really big. And the whole body has to crouch down and then all stand to your tippy toes to get to the top of the A and then back to the bottom again. That is a scaling thing, right? You're creating the same outcome, but you have to do a completely different motor activity to accomplish the same feat. So caudate nucleus and so on, this thinking kind of part of motor planning, you can see how that can be very helpful. Also, the caudate nucleus is good for quick decisions based on past memory. An example would be you've driven a car all the time, and every once in a while someone pulls out in front of you and you have to slam on the brakes and turn to avoid. That's a cognitive thing. That's a complex decision, and the caudate nucleus helps to make that motor decision quicker and more efficient for you. There's a lot of neurotransmitters that are involved in the basal ganglia, but probably the most important ones are the two inhibitory ones, GABA and dopamine, especially dopamine for the substantia nigra. That's over here. Well, where is it? Oh, there it is. The substantia nigra is over here. And the excitatory one that's of particular note is glutamate. So back to some of our disorders. Here we have Parkinson's disease, or PD for short. And The kinds of movement problems you have with Parkinson's disease are bradykinesia, that's slow movement, or akinesia, or just difficulty or even absent movement in some sense. In fact, some of the things you notice about Parkinson's patients is how blank their facial expression is. It takes so much effort to move muscles that it's just not worth it, to put the effort in to move your face for expressions. So that's why I know it's kind of blurry here, but that's why they call it mask-like face, or appearance in their face. Rigidity, which is, the muscles are kind of just stiff overall, but you have a resting tremor. And the head sometimes will bob like this, or your hand will have that pill rolling. They describe it as a pill rolling. If you're rolling a pill between your fingers, that kind of shaking in the hands is typical. Dyskinesia just means abnormal movement, not necessarily without movement. So that's another kinesia type of word. Freezing of gait, meaning you have this kind of halting, shuffling kind of gait. Parkinson's patients also tend to have problems with dementia, depression, and hallucinations. Now the depression, I don't know if that is because of Parkinson's or as a result of Parkinson's. You might be depressed because you have these problems, but it could also be caused by the problems themselves. Often sleep, sensory, or emotional problems come with these individuals too. Their posture is very stooped. Their arms are flexed in there. They don't swing their arms much when they walk. They sort of shuffle. Huntington's chorea, or Huntington's disease. This is an autosomal dominant disorder, and meaning that if you inherit one gene for this, you will end up getting this. Fortunately or unfortunately, depending how you want to look at that, your youth is fine. You don't tend to have any manifestations of the disorder until you get older, and then they show up after you've passed them on perhaps to your children, these genes. But it starts usually with the chorea, the flicking kind of motion that we talked about, but then other distortions will develop as the disease progresses, like hemibolismus or athetosis or some of these other things. Dementia is also associated with Huntington's, and this is associated a lot with GABA secreting neurons, that they're not functioning, and to some extent acetylcholine releasing neurons within the basal ganglia, and those are more associated with the dementia issues in Huntington's disease. So you have cognitive, motor, and behavioral problems. I made a big motor summary that reaches back into some earlier discussions in our previous unit even, so that motor control is, as you have probably surmised, has a lot of bits and parts to it. You have things that are simple, like at the spinal level for simple reflexes, and those simple reflexes can be automatically triggered by, just sensations of various sorts, like the flexor reflex and those sorts of things. However, some of those patterns can be set into motion by higher centers if you want to, but you can use those same pathways rather than reinventing the wheel. The hindbrain, vestibular and reticular formation, having to do with maintenance of posture and the tone of postural muscles for standing or other using your core as your framework for your extremities to function. Also helping with the maintenance of equilibrium when there's anything that perturbs your equilibrium, like with the vestibular apparatus and so on. And then we had corticospinal tracts, which are more the direct tracts from the motor cortex down to directly control either the distal extremities, or to activate spinal patterns that are already hardwired, like the walking pattern or any of those other sorts of things. Cerebellum and basal ganglia we just covered, so again, this is just a quick little summary. If you'd like to look through that yourself, that's fine. But that's our motor section. So I think that's the last one. It is. We will look at the cerebral cortex and some other things with that next time.